Welcome to this Step 3 review on dementia and cognitive impairment, brought to you by Roadmap to Residency. Dementia questions on this exam are rarely about reciting a definition. They are about a worried family member in your clinic, a screening score, a medication decision, and a caregiver running on empty. Our goal is not to reteach neurology. It is to show you how these stems are built and how to attack them. Work through your question bank alongside this video, because these patterns lock in when you do practice questions. Let us get started. Here is what we are covering. First, how to read cognitive screening stems, and what a score on the Montreal Cognitive Assessment or the mini mental state examination is actually telling you. Second, the medications for Alzheimer's disease, when the exam wants you to start one and when it wants you to hold back. Third, behavioral management, where the most tested principle is that you look for a cause before you reach for a drug. Fourth, caregiver support, which shows up more often than people expect. Along the way, we will walk through practice questions and explain why every answer choice is right or wrong. Our first strategy is to decode the screening stem. Screening is not diagnosis. When a question hands you a low score, that score says there is a problem worth chasing. It does not name the disease. So the next best step is almost always to work up reversible causes, not to declare Alzheimer's disease and not to prescribe. Test writers count on you skipping that step, and they will offer you a satisfying diagnosis right in the answer choices. Second, every cognitive stem is secretly a three-way sort. Listen for the tempo. Acute onset with attention that waxes and wanes is delirium. Sad mood, poor effort, and a patient who complains loudly about memory is depression. Slow decline over months to years, with the family more worried than the patient, is dementia. Find the tempo and you have found the answer. Strategy 2 is the medication trap. First, know the two classes. There are only two families of medication for Alzheimer's disease, so this is very learnable. The Cholinesterase Inhibitors, with Donepezil as the one you will see most, and a medication that blocks a glutamate receptor, Memantine. Mild to moderate disease favors a cholinesterase inhibitor. Moderate to severe disease is where Memantine comes in, often added on rather than swapped in. Match the class to the stage and most medication questions collapse. Second, expect a modest benefit. These medications slow symptoms, they do not stop the disease, and they do not give back function already lost. So any choice promising reversal or cure is wrong on its face. And watch the side effects, because a cholinesterase inhibitor slows the heart and stirs up the gut. The exam hides that as a new complaint at a follow-up visit. Strategy 3 decides the most questions. Behavior first, medication last. First, hunt for the trigger. When a patient with dementia suddenly becomes agitated, something changed. Look for pain, constipation, a urinary tract infection, a new medication, poor sleep, or a move to an unfamiliar room. Sudden behavior change in a stable patient is a medical event until proven otherwise. Second, reach for the non-drug answer. Redirection, a consistent routine, familiar objects, good lighting, and caregiver education are almost always first line. They sound too simple to be right, and that is exactly why they are right. Choose the behavioral option before any medication unless the patient is a danger to self or others. Third, know the never choices. Restraints make agitation and injury worse and are essentially always wrong. Antipsychotic medications carry a serious mortality warning in older adults with dementia, so they are reserved for genuine danger, not for wandering. And benzodiazepines invite delirium and falls. Our first practice question tests whether you know the difference between screening and diagnosing. A 72-year-old woman is brought in by her daughter, with 2 years of worsening forgetfulness. She misplaces items and repeats questions, but still dresses and bathes herself. She is not sad, and notably, she denies anything is wrong. Vital signs are normal and her attention is intact. She scores 22 out of 30 on the Montreal Cognitive Assessment. Notice the tempo, notice who is worried, and notice you have been handed a screening score and nothing else. Read the options and commit to an answer. Let us break this down. First, spot the pattern. 2 years of gradual decline, attention fully intact, and a patient who still handles her own care. The family is worried, and she is not. That tempo rules out delirium, which is acute and fluctuating, and rules out depression, where the patient usually does the complaining. This is dementia, and the score confirms real impairment, but that score does not name a disease. Second, apply the rule. A positive screen obligates you to rule out reversible causes before you diagnose or treat. Thyroid disease and vitamin B12 deficiency are the cheap, treatable culprits this exam wants checked. Third, eliminate. Starting Donepezil treats a diagnosis you have not made. Brain imaging has a role, but not ahead of cheap reversible causes. Diagnosing Alzheimer disease off a screening score skips the entire workup, which is exactly the error being tested. The answer is to check thyroid-stimulating hormone and vitamin B12. Our second question is about behavior first, medication last. An 80-year-old man with moderate Alzheimer disease in a nursing home has become agitated and combative over the past 2 days. The crucial phrase is 2 days, because he was calm and cooperative before. He is pulling at his clothing and resisting care. His temperature is normal. And here are the details planted for you. He has not had a bowel movement in 4 days, and he winces when his abdomen is examined. Notice this is an abrupt change in a stable patient, and the stem is quietly handing you a cause. Pick your answer. First, sudden change means look. This is an abrupt change over 2 days in a man who was calm before. That is not the natural march of dementia, which moves over months and years, not over a weekend. So something happened, and the stem is not subtle. It hands you 4 days without a bowel movement and abdominal tenderness. A patient with dementia who cannot tell you he hurts will show you instead, and the way he shows you is behavior. Now, why the non-drug answer wins? Evaluating for pain and constipation treats the real problem, and the agitation resolves when the cause does. Haloperidol sedates a man whose issue is a full colon, and antipsychotics carry a mortality warning in dementia, so that is a double error. Restraints make an agitated man more agitated. A benzodiazepine invites delirium, and falls in exactly the patient who can least afford either. Every distractor manages your discomfort rather than his problem. Caregiver support shows up more often than people expect, and it is easy to dismiss as filler. First, screen the caregiver too. When a STEM spends a sentence describing the exhausted spouse who has stopped seeing friends and is sleeping poorly, that sentence is not scenery. That sentence is the question. Caregiver burnout is tested directly. Assess the caregiver for depression and offer respite care, adult day programs, and a support group. These are correct answers. Second, plan before the crisis. Early dementia is the window for the hard conversations, and that window closes. Advanced directives, naming a healthcare proxy, driving safety, home safety, and finances all belong there, while the patient can still participate. So, when a STEM tells you the patient still has capacity, every planning answer moves up your list. Our third question rewards the doctor who reads the whole room. A 78-year-old woman with moderate Alzheimer disease comes for follow-up with her husband, her sole caregiver. She is stable on Donepezil. Now listen to how much of this STEM is about him. He looks tired. He has stopped attending church. He no longer sees friends, sleeps poorly, feels overwhelmed, and has lost weight. Meanwhile, she is calm and her examination is unchanged. Ask yourself who in this room actually has a new problem. Choose your answer. First, who actually has a problem? The patient is stable, calm, and unchanged. Read the STEM again and notice every new finding belongs to the husband. Withdrawal from church, withdrawal from friends, poor sleep, feeling overwhelmed, and unintentional weight loss. Line those up, and you are looking at a depression screen walking through your door, and he is describing textbook caregiver burnout. Now the key distinction. Increasing Donepezil and adding Memantine both treat a patient whose disease has not changed, and neither touches the real problem in the room. They are there to reward you for reflexively reaching for a prescription. Immediate nursing home placement leaps past every less restrictive option, and respite care exists precisely, so families do not have to make that leap. The answer is to assess the husband for depression and discuss respite care. Here is the exam day pearl that ties this together. A 2-question filter you can run in about 10 seconds. First, ask the tempo question before you look at a single answer choice. How fast did this develop? Hours to days with fluctuating attention is delirium, and you hunt for a cause. Weeks with low mood and poor effort is depression. Months to years with the family more worried than the patient is dementia. That one question eliminates most choices before you have read them. Second, ask who is suffering. If it is the patient and the change is abrupt, go hunting for pain, infection, constipation, or a new medication. If the new problem belongs to the caregiver, the answer is about the caregiver. STEMs are expensive to write, So when a question spends real estate on an exhausted family member, it is telling you where to look. That wraps up our review of dementia and cognitive impairment. Remember the core ideas. Sort by tempo before you read the answers, because delirium, depression, and dementia are 3 different questions wearing the same coat. A screening score tells you to start looking, not to start prescribing. Match the medication class to the disease stage, and never expect a cure. When behavior changes suddenly, find the cause before you reach for a drug, and remember that restraints and antipsychotic medications are traps more often than answers. And when the STEM spends time on an exhausted caregiver, the caregiver is the question. Drill these patterns in your question bank under timed conditions and read every explanation. Work through the dementia and delirium chapters of your main review book and the geriatrics and behavioral health sections of your question bank. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped, please like and subscribe so you do not miss our next session. Good luck on your exam.